are events on depression in congregations. For those who are unfamiliar with the ICMH, we are a joint collaboration with both the Center for Interfaith Cooperation and the National Alliance on Mental Illness, specifically NAMI FaithNet and NAMI Greater Indianapolis. We aim to connect the members of various faith communities, mental health professionals, and other service providers together in order to help address the needs in our community. This luncheon, we're going to have the opportunity to learn about what depression is. We're going to also learn about how it can affect people in various faith communities, as well as concluding with an interfaith prayer service and sharing the resources that are available that can maybe help solve the issues that we have today. Today's luncheon will consist of both a discussion as well as the prayer service. As I have stated earlier, our panel moderator for this today will be Dr. Armand Siddiqui. Dr. Siddiqui is a psychiatrist at Adult and Child. He has been in the field since his graduation from medical school in 1996. And in addition to working with Adult and Child, he is also affiliated with Community Health Network, the Lutheran Hospital in Fort Wayne, Indiana, St. Joseph Hospital in Fort Wayne, and the Parkview Hospital in the city as well. And in addition, he is also a steering committee with our Interfaith Coalition for Mental Health. Our panelists specifically will be Pastor John E. Girton Jr., also known as Pastor G. He is the senior pastor of the historic Christ Missionary Baptist Church in Indianapolis. He serves also as the executive director of the Indiana Healthy Marriage and Family Coalition, Inc., and the CEO of the Mass Media Group, Inc. And without further ado, we will start with the panel and bring both the doctor and the pastor up.
Thank you, Nilo, for the introduction, and thank you, Ben and Carol and the steering committee for organizing this. And good afternoon, everyone. My name is Armand Siddiqui. I'm a psychiatrist, as Nilo said, and working basically in Indianapolis, working as a child and community, taking care of the patient unit, one of them in Howard. I have no disclosure. I'm not any pharmaceutical company. This speaks person. I don't speak for any pharmaceutical company. I'm not in any pharmaceutical board, so I have no disclosure to disclose right now. So thank you, Pastor G, for coming here and having this opportunity to talk in front of us and see that what difficulties we face in congregation about depression. First of all, that mental health, what is mental health as we suffer as a nation, as an individual on this continent, or in the world, that any abnormality in thinking, your emotions and behavior is a mental illness if it is significant enough that it is the distresses that it is causing so much impairment in your social, your work, or your family activities. If you're not able to do that, then it comes in the category of mental illness. What we are discussing today specifically is depression. The depression and anxiety both goes hand in hand. Anxiety is one of the prevalent mental health conditions, but we're not talking about anxiety here. But depression, how much prevalent it is? You should find one paper up there on your table that how prevalent is this, and this is based on the National Survey of Drug Use and Health, that 6.7% of U.S. adults have depression. So 1 out of 100, almost 7 people, is suffering from this depression. And how many usually get into treatment? That's the main thing. And if they're getting treatment, what type of treatment they're getting? If they are not in services, what barriers they are having not in services? Out of those 6.7% of U.S. adults who are suffering from this depression, which we will talk about briefly what it is, only 37% of them, almost 40%, did not receive any kind of treatment, which means that they did not go to any health professional, which is not talking about psychiatrists or nurse practitioners, any counselor they didn't go to. So they didn't even talk to anyone about that, but they're suffering from it. And so out of those, 13% will receive from the health professional that do not prescribe medications, and 44% will receive medications and therapy both. Why? Because most of the prescribers do believe evidence-based, research-based, that the combination treatment model with individual psychotherapy and medication is the most effective treatment modality to do. And 6% of only medication only, that can tell you also that why only 6% of medications only, because most of the prescribers, myself, also believe strongly in psychotherapy, because depression comes in sometimes endogenous as well, but most of the time our social, what is contributing to us in our daily life, causing it. Now, in adolescence, there are even more, 9% of the population is suffering, and what is eye-opener, the 60% did not receive any treatment. So why it is? Because the main thing which I always talk about, it is not a talk of mental illness on every dinner table. It is not. Whatever the reason is. Either we are so stigmatized about it, either that we don't want to talk with our children about depression, hey, you will cope with it. And I hear with this all the time when somebody is diagnosed first time with depression, and there's difference between just depression and depressive disorder, which we'll talk about, that they get so scared. Like major depressive disorder, it is a name to major depressive disorder, but it does not mean that it's the end of the world. So unless we are, as a society, that I appreciate each one of you for coming here, as a society not able to address this in every dinner table, we will not be able to address this as a society. So just a quick thing, what is depression? Depression is something when somebody is feeling sad, depressed mood all the time. Now, I will clear this myth that everybody can have a day where he's feeling blue, not feeling up to what he wants to do, just want to lie down, but you don't categorize it as a depressive disorder. But if out of the 9 criteria according to Diagnostic and Statistical Manual of Mental Health Disorders, how we diagnose it, that number 1 is feeling sad all the time, every day, all day, don't want to do anything. Second, do not enjoy things, not having any pleasure in doing things. Suppose, especially someone who you're talking in your congregation used to play basketball, and now he does not want to play basketball. He used to be very active in your congregation, but is now not showing up, or he's not enjoying the things which he used to enjoy. This is the second symptom. The third is that either sleeping a lot or not sleeping at all, sleep disturbances. Early morning awakening, which is not a usual pattern. You are seeing a change in the pattern from someone who you know, or multiple time awakening during the night, having a lot of thinkings in his mind. Now, appetite disturbances sometimes, not feeling hungry, losing weight, significant amount of weight loss in about few weeks. You see that what is going on. Or atypical depression, we do see sometimes patients come to us and they have coping skills that they eat a lot. They have gained, and I've seen this in adolescents too, when there is no outlet for that adolescent to express their feeling, they feel that they're just in a box. They self-cope themselves with eating, so they are gaining weight more. So that's the third thing. The fourth, actually, the disturbances in appetite. Now, feeling sluggish and feeling tired all the time, and not feeling up to what you used to do, and feeling low energy, low motivation, and not able to think or focus, concentrate. Concentration is not as much as we used to do. I have some patients who came in with have a career in brokerage, but now having difficulty in easy math calculation. So what it is early onset dementia, or is something that have significantly debilitating depression, that have difficulty in focusing and concentrating. Also, recurrent guilt, hopelessness, If somebody comes in the congregation trustee and said that, I don't think so that the things are going to go my way. It is going, I think it's going to be negative, whatever I do. It's a snowball effect, feeling of guilt, something, and feeling of hopelessness. Then there comes the recurring suicidal thoughts. If somebody is having those suicidal thoughts, that recurring suicidal thought, sometimes it comes up, no, I don't want to die, but world will be better without me. Or I just don't want to live anymore, but I don't have any intent or plan. Now, here is the red flag that if it is coming, then there's that line demarcation that you have to get the immediate help right away. So out of these, any of these criteria is meeting, is depression going on. But if out of these 9, you are having 6 or 5 criteria, 6 criteria, and for 2 weeks, then you are suffering from an episode, major depressive disorder. If every day, all day, you are having these symptoms, then you are suffering from major depressive disorder. So, and that time you would need help if it has been going on for that time. Now, this is just the easiest, simpler way to describe what is depression and how we diagnose depression and how. Now, in congregation, what we were talking about to get this model here for today's luncheon, and Ben brought up this idea, and thank you, Ben, for bringing it. This is because that is all this about interfaith, how to bring the churches, how to bring the synagogues, how to bring all the congregations come together, because to us, when we see them, it is the lost, and they see them, the frontliner, and how to recognize it, the early onset of depression, how to see what is are you equipped with that to recognize. So thank you again, Pastor D, for coming. My first question with you is that, in your congregation where you meet, do you think that the people out there are having this mental illness, are open coming up to you, and do you have the training you need to identify someone and forward them with some resources?
Yeah, is it someone?
How's that? Yeah. Thank you all for inviting me to be a part of this. Okay, you asked about 5 questions. So let's start with, I believe you're asking that there are people with this issue in the congregation, is that correct?
Yes.
Okay. Most definitely. There's not always clear, and I think any clergy in here knows that particularly if you're with the African American experience, Sunday is supposed to be a day where you put on your Sunday's best. And so in addition to putting on the right hat, the right clothes, you also put on the right smile. You put on the you put on the right attitude, you put everything on right. And so it's not always easy to look at someone and see what's really going on. But because of my own bouts with depression, I know that there are ways to get over it and to make people think that things are okay when they're really not. And so even in the process of recognizing that it's in the congregation, there is an additional responsibility, at least I feel an additional responsibility, to develop enough of a relationship with those who I see on a regular basis to be able to detect some upticks in certain types of behavior. Whether that is they didn't show up, someone who's normally there all the time is not there, someone who sits further in the back, someone who starts coming later and later and later, someone who used to come with a spouse but only comes by themselves now. You feel, and so in essence, I'm looking at the psychosocial activities that are going on. Someone that has let us know that they lost a job. Clearly, when I have to do a funeral, I'm paying very close attention to the family of those. When they've lost a loved one, I'm paying attention to other family members, making sure that the children are showing up, or things like that. So we recognize that it's there. It's not always apparent, it's not always easy to detect, but those who have a commitment have a much higher chance to actually be able to identify. And then we move to at least one of your other questions. So do I feel trained or prepared with resources to actually help them? I can say that for me, I feel a little more, I think the word you used, tuned in. I can't speak for other clergy and faith leaders. I'm tuned in, but I suspect that too many of our faith leaders are not tuned in. And by tuned in, here's what I mean. I've taken classes in counseling, psychology, and I've taken classes, but that's it. So that's all I can claim. I don't have a degree, I don't have any of that, right? Now my wife is a social worker, so kind of living with a social worker kind of gets on you. So there are some things that I recognize that I probably wouldn't without her. So y'all don't say nothing to her when y'all see her. But I'm the one that got her master's degree, okay? I feel like I wrote the papers. But I don't think that, I think that too many of our faith leaders are not, forget about being trained, they're not tuned in. And they've got a lot of other things going on. And trying to keep up with all of those other issues that people have, I think, could potentially be a tipping point for some of our faith leaders who just aren't tuned in.
When you're saying this, that they are not, like you gave example when you were talking earlier that out of those all churches, 4 or 5 churches were in there, or pastors of the congregations were in there, right?
Correct.
So, now, when they are not up to speed with this, what is the barrier there?
Okay, well, we're talking about the faith leader or the church in general?
Faith leaders, if they are not.
Okay, I think many of you all kind of know where I am on this one, so I'll just restate. Particularly in challenged community, underserved communities where, you've got drugs, you got crime, you got violence, you got homelessness, you got, truancy, and you've got a lot of issues. Mental health is just one more of many issues. And so you kind of have to choose your weapon. What are you going to focus in on? In communities like this, many of those pastors, this is not their full-time job. They're bi and tri-vocational. They're doing other things. And so it really is not fair to expect a pastor of a congregation to be an expert at all of these different things, to be on all these different panels, to be at all these different events, because we really have to choose what resonates with us, and that's where we really need to stay. And so I think when you have 50 churches in a particular area and you get 5 to show up, I think we need to celebrate, me personally, because those are probably the only 5 who have the ability to show up, or the others are focusing in on something else. They're focusing in on the fact that we don't have a grocery store, or they're focusing in on the homicide rate, or they're focusing in on, education, and that's okay. I don't go to the education things because this is my focus. And so what I want is I want to support the faith leader who does go there, that they go get the information, they can bring it back and share it with me. So I think that's a little bit of what's going on, and the reason why you don't see a lot. I don't think it's that churches don't care. I just think it's that they've got a lot on their plate, a lot to deal with, and you get what you get. And I think we have to figure out ways of working with what we get, what we receive.
I think we all agree that we all care about it.
Exactly.
And how much this is prevalent with all those things which is happening in society, about violence, about marital issues, about all those which, and every church is doing its best to address those. But the numbers when we speak to that, if 200, 300, 400 people is coming on the Sunday congregation, if 400 is coming, 7 out of 100 having some mental illness, right? If they're not in treatment. Do you think all of this, like not having enough resources, not having enough time to deal with different issues, do you think there is somewhere stigma also there that we don't want to openly talk about mental illness?
So most definitely there's a stigma. And again, I can't speak to other faith communities or other cultures and whatnot, but I know particularly in a church like mine, which is predominantly African American, the stigma is huge. I do believe, I made that word up. You can't find that word. Ginormous, huge, whatever. It's huge. And I don't want to belittle the issue here, I know, but think, though, that some of the recent exposure that the issue is receiving from some of the more high-profile individuals who have come out and admitted that they have had bouts with depression and bipolar and schizophrenia, whatever. I think that is helping to break down, and particularly in our communities when you have athletes who have come out to admit their challenges. And so I do believe the barrier is coming down. And I also say this, we were talking about faith leaders and some of the challenges of getting faith leaders to like you said, they all care about the issue. They're just not able to maybe move around and be a part of the different groups that are working on that issue. But what I also see is that many of the people who are sitting in the pews are finding ways to get involved in these issues. So what I've noticed is that even if I don't get a large number of pastors or church leaders to show up, I do see a lot of the folk from the pew who do show up. And that's been encouraging to me, right? That people have just said, my pastor, that's just not an issue, that he doesn't have time, but I'm going to go and I'm going to get the information and I'm going to bring it back and I'm going to present it to the pastor, or I'm going to take up that banner. And that's very encouraging.
I think that's the first step to it, and I think that's why we all are here. And even if one of here goes to like 4 other pastors, 4 other leaders, and share them what we learned here, I think that's the thing.
Right.
And another thing which I want to ask you is that I do hear this in my practice too a lot about depression when somebody's on medication and therapy. They do feel the first question, how long I have to be on medications, or does my child has to be on medication? Does it really suffering from that illness? When somebody in your congregation comes and speak to you that this medication I'm taking, I feel that I am the only one and I'm suffering in this and I'm different from someone else. Somehow the mental illness is different from some diabetes. The same thing, they take the medication every day. Or somebody has thyroid issue, they have to take early morning every medication. But why? Why on the dinner table we are openly accessing or talking about, hey, did you take a diabetes pill? Or why nobody who has diabetes questioning that, do I have to take, they are different. That culture, how we can, because we appreciate all the congregation, all the pastors, all church leaders, how we can, because if we start that very early in our churches, and talking to young mom, dad, if we take that thing when the kid is 2-year-old, 4-year-old, to talk about it, maybe in 30 years from now, we are much better with stigma. Okay? And the statistics are saying that we are much better now than we were about like 30, 40 years ago. But I think one thing which we need to address more, and I do that with my children, parents, and grandparents, if we can talk about it openly, do not show your body mannerisms. Do not show anything that this is something to hide about. Or this is something that you are uncomfortable talking about. Do you think something faith leaders can talk actively in there about it? Because if I know that what faith leaders can talk can impact their lives, right? What they come for is with a smile on Sunday morning. Right. Sunday evening can be a discussion on the dinner table.
Can we talk? Can we talk?
Yes.
I'm gonna lean in some. This culture of this, it ain't none of your business culture, is really driving a lot of what we're talking about. This, I don't want nobody to know outside my house what's going on in my house, right? It's driving a lot of this. And maybe in the 30s, 40s, 50s, 60s, pastors had a level of respect that they could sort of say things and people did them, or they abided by them. Unfortunately today, pastors don't share that same level of respect, especially with the communities that need it the most. And these are communities of folk who may be suffering and self-medicating, or doing some things to try to feel better about the situation. And so even as a pastor, I realize there's only so far I can go before that person pushes back and says, "That's not, I know you're my pastor, but that's none of your business." I don't like saying that, but I'm just being honest. There are folks that just don't want nobody to know what's really going on. And I have an actual example of a family who a young man was coming to the church, and I had a conversation with him, and like I said, I'm a little tuned in, and I was kind of like, okay, y'all know what that means, right? Okay. So his mother wasn't there, so I had to go to an aunt and say, could you kind of give me a heads up of what I'm dealing with here? And I mean, she gave it all to me. And it took probably a year before I even saw the mother show up, right? And I think the only way we were able to get the barrier broken down was that the mother realized that I cared enough to stay in contact with the son. Even she never told me what was going on. He never told me what was going on. It took somebody outside, an aunt, to kind of let me know what was happening. And so that's one person. Now, if I'm looking at 300, and out of that 300, I mean, one day I had a guy who was bipolar and schizophrenic, double diagnosis, in my balcony. I mean, I'm doing everything I can to get somebody to go up there and make sure that he's okay, that he doesn't jump, he doesn't fall, or something like that. And again, the mother didn't tell me, he didn't tell me, and so I'm trying to figure out, how do I gain information about what I'm looking at? Because if I don't have anybody to ask and won't nobody tell me, then I don't know. And this is part of our challenge as faith leaders, that people aren't as open as we would like them to be, so that we can understand what's really going on, so we can help them get the help that they need. This is part of the challenge. I don't know what was going on in that house. I don't know what was going on with that mother and that son. But I know that when he showed up, I had to use everything I could use to try to figure out what is going on with this guy, if that makes sense. And there's a fine line, because again, you go so far, they'll push back, and they won't. And the way you know they push back, they won't show up next Sunday. Or they won't show up for a month or so, and then you're like, okay, that means I pushed too hard. I asked too many questions. Right? So.
But you mentioned a good example of that person who has bipolar schizophrenia, or probably schizoaffective disorder, and you are noticing that he has been diagnosed with this. You know about him. And he is on the balcony, he's making you uncomfortable, that you said that he might jump or something. Do you think at that moment, if you have to call somewhere, scramble, what should I look for, who I should call? Do you or your church has the information where to call?
At my church, again, because I'm drilled in, I'm focused. I have a retired nurse who, she knows what the look is. She knows the look. And the look means something's going on if I'll track past her. So I'll look at her. She immediately knows, okay, something's going on. The other thing in a situation like that, if a family member was close, the first thing I'm going to do is try to find a family member who would know more about the situation than most people, and I would direct them to kind of go deal with that. And that's what I would do. Now, the retired nurse, we have a ministry at our church called We Care. They have access to my man back there in Hamilton. They have access to other treatment centers. I have on my phone some counselors that I could get to fairly quickly. So, and there are even times where I even call psychotherapists and had them come to church intentionally, because I knew that I was preaching a message that might excite people in a certain way to actually make a move if they were depressed, or if they were going through something, or they did have something in their life or whatever. So I would literally call someone and say, I need you to show up at church today. So I think that for me, I'm a little more keyed in, but I can't speak for if that same scenario happened at another church, if somebody was able to look at somebody and they would know that means it's time for me to go do something.
Do you think that we, as a mental health coalition, if we bring up all the churches or anybody from the audience can answer this too, have will help that if we will give some where to contact the first priority, where to go from here if you see anything unusual in your congregation, where to go for help. Because what I hear sometimes that they don't even know where to call at that time. You, as you said, you have been doing this, and you were so. But do you think this is a norm in every church or in every congregation?
I would hate to try to say, because I just can't speak for other churches. Let me go back and say that when I started at the church that I'm at right now, none of what I'm talking about existed.
That answers it.
There was no We Care network. There was nobody calling any psychotherapists to show up. I don't think there was a sort of a connection between the leadership and those in the pew to say, hey, if somebody walks in here, I need you to go do, what is it, mental health first aid and figure out what's going on and then call the authorities. That didn't exist. So if most churches were like Christ Missionary was 3 years ago, then I would say most wouldn't know what to do or who to call or, because things like that happen fast. And if you're not really ready.
Right.
Then,
and that's what, and the first thing comes is are you ready to learn about it? If you're ready to learn about it, then you learn. And then if the resources are available. So anyone from here, from the audience, do you think that it will help if we will do something go to the churches, go to the congregations and give them some list, even if they are not, the boundaries as you said, they are not that much willing to come or somebody, but do you think it will help if we will provide some immediate right to access things?
Really quick, please note everyone, today's luncheon is being streamed in video, so I just wanted everyone to know that that's not the norm for our luncheons, so just please.
So if you're wanted by the police, a warrant out for you, write your question down, and give it to the person next to you.
I think in the age of social media and electronic media, if all the churches that have web pages or websites, if they could find some way to put these resources up, post them on their page. Sometimes we don't want to ask. And remember, you were talking about the Sunday put everything on. That's just one of the many masks that a lot of people wear.
Very much so.
They get up every morning, and whether they go to work or social activity, they just reach in the drawer and figure out which mask am I putting on today to get out the door. And one other thing.
That's so true. She said that, yeah, I just signed up to repeat everything that everyone said. But she said that one of the things she said was that the mass of people getting dressed every Sunday and putting on the face and everything, that's just one of the many things people do, getting up every day to put on which mask am I going to put on today. You said you had something else.
And I'm just going to ask, a lot of clergy across the country are now saying, are now also coming out, if they have mental health issues or suffer with depression. I don't think there are enough resources for the ministers to go to or clergy to go to in a place of safety where they can say, God, whoo, I'm really feeling this way, or one of the mothers of the church died, and she raised me from cradle roll. And I think that would be helpful too. And it might be much harder in the African American community because we're not trying to be depressed, mentally ill, anxious, any of those kind of things, but we are.
Can I address that real quick? She's what she's saying about what she's saying about pastors. I had the unfortunate experience of having to funeralize those 4 little girls that died in a fire in Florida. And in 2016, I had to either officiate, to preach, or attend almost 40 funerals that year. We had high violence going on, so Jalen Johnson was one of them. A lot of stuff was going on. And I remember when I got the call that I had to do the eulogy for the 4 girls, I made some immediate phone calls to some other pastors or ministers, whatever. They weren't pastors, a couple of them. And I said, hey, I need some support, because I knew that was abnormal, and I knew that it wasn't going to be easy, right? And so they did. One young man, these weren't members of my church. One young man actually went up there with me. He stayed with me the whole, and they weren't African American either, okay? One guy went up with me, stayed with me in the hotel. The reason why I'm saying that is that I'm going to also challenge others. Keep your eye on the pastors and don't think for us, right? Help protect us, because as soon as I finish that, I have to go, you shake it off, and I have to go right back to the next thing, or to the next funeral, or to the next hospital room, or to the next whatever, to the next whatever. And what I don't feel a lot of is I don't feel like anybody's watching me. And I don't feel like anyone's thinking, you know, I just did a funeral Tuesday, just this past Tuesday. And then as soon as I get done, you get this, oh, this is a great eulogy. But I'm about to fall over. You didn't realize what it took for me to do that. And so rather than get, you know, Pastor, you really need to, you know, hurry up, get your food, and get out of here. That's okay, because I needed that day. And it didn't happen. So I hope you understand what I'm getting at. For those people that you see running in and out of hospital rooms, eulogizing, showing up for people in these critical, and my dad did that for 27 years. I didn't want to be a pastor because I saw my father bring people into the church. He married them. He went to the hospital. He buried them. He shook it off and did it. And I sat there and I said, how do you do that? And I never wanted to do it because of that. And now here I am doing the exact same thing. And I want to be smart. I want to be wise. And part of that is getting people around me who can detect, you need help. And then I go through it, you know.
I'm a British Schweitzer. I happen to belong to IC. But I'm a psych mental health nurse. So you're talking about your nurse that you have. First of all, just for you personally, that's one resource. Oh, sure. That's one resource you have right now. She needs to know that it's okay if you say something. That's very important. And anyway, what I was going to say overall was, I think it's stigma. A lot of what we're talking about is just plain old stigma and how you approach it. And so it sounds like you've done some really great things approaching it, like one-on-one, being able to pull out, you know, people that need help and get resources. The other side of that I'm trying to do now is do it as an educational process that is ongoing and addresses the health promotion and wellness. Sometimes when people hear it from that side, it's easier than mental illness, you know, it's wellness. And you brought to mind a story about, we told at our temple actually, is when somebody is sick, what do? You bring them a casserole, the caring committee or whatever you call them, you know, brings them something to eat, goes to visit them. If you have your surgery or whatever, what happens with mental health? They have an illness? Does anybody get a casserole? Probably not, you know. So there again is a simple thing to do, but including all kinds of illness is a really important thing, I think, to do. And the other is, I teach mental health first aid, I think I've said before, but it's a wonderful way, and in congregations I've done that with, to actually introduce the idea of mental health and illness, and that there's hope, and it can be helped. And helping people to learn more about it, to talk more about it, and then being able to follow up as a group within that community, I think is really important. So, that's my thoughts.
Thank you for bringing that up, and thank you for your service as a psych mental health nurse. It's not an easy job too. And thank you for bringing a very important point. I think that is the main core issue here, stigma. The stigma that we're now talking about, and what you said, that if somebody is diagnosed with depression, are we going to go in and start becoming welcoming them? Are we a welcoming community in our congregation? The one thing which I would say, when in the practice also, that's where in congregation you would see that person needs to go to a healthcare provider. If that has been going on for a long time, if Pastor G, if you've seen some change in behavior, if you've seen that someone has talked to you that they are giving up stuff or they are writing some bills or something, then that is a red light there that you have to send them right away. But the mental health resources and the stigma needs to be addressed by every one of us. I think it's a responsibility of each one of us. Doesn't matter where we practice, where we live, we all together can do that. And if we become the welcoming community in our congregation, in whatever congregation it is, if we even two line welcoming community, that how many people have been suffering with depression. Even little by little in that congregation, if you talk about it, I do believe, and I understand that you said that you don't want to push them, there's a limit, this is mine. But the same thing, they don't care about if you will say about diabetes, as I said, for thyroid disorder or anything. They will come to you, I had a heart attack, Pastor G, and what will be I had a stent placed. They are not ashamed of it. They will not push you to why for depression. And I think some of it led me to think that we in ourselves are uncomfortable talking about it. And that's and not talking about you, Pastor D, but you are more to there. But it comes from us. If we are uncomfortable talking about it, we are not be able to express this to our audience, whoever it is. And the people who are sitting in front of me are more smarter than who I'm talking. They can judge from your appearance. They can see that your uncomfortableness in there. They will never come to you and talk about it because you are not as open about it by yourself too. I think that's the main core point here, that we have to address this in every congregation.
And real quick, as you were talking about, the mental health first aid and whatnot, one of the things that we do, or that I do very specifically, is that I push for individuals to gain some type of training because they are closer to the people than I may be. So, I mean, literally, if they're sitting next to someone, and there are times when I do know things that are going on, and when I'm preaching, sometimes I'll even say, I think I know too much. And sometimes I do feel like I know too much. But because of that, what I'll do is, for instance, I may mention that I had a lady whose son had committed suicide not long ago, and based on the text messages that she was sending me, I knew, okay, I need to stay close to her because she's dealing with grief and all the other things that go along with it. He was a young man, and so when she would show up at church, I would let my wife know to make sure that she kept her eyes and just watched that situation. She didn't have to know all the details. All she had to know is that my husband, the pastor, knows enough to know that we need to watch this lady. And one day she came in and she went up to the balcony, and I put my eyes on somebody, and I did one of these, and they knew what that meant, right? And I need them to be on guard because they're closer to the situation than even I am. So,
I'm with Alpha Kappa sorority. We partnered with FaithNet, and we had a program at Pastor G's church. And I think the question that I'd like to ask him is, how do you think community organizations can help the church become more aware of mental health conditions? Our role with the sorority is to break the stigma in the community about receiving mental health services. Did we do that when we came, and how did that help? And what do you think are future things that we could do to support that?
she's talking about what was it called? It's called Hope. Hope on Pain Ends, which is something that we've done 2 years in a row, 3 years in a row, in October. And let me just say this. The main reason why I was all in is because I too suffered with depression, and I was trying to find a way to use my pain and give it purpose. And so you all kind of showed up and met me at a spot. You know, I'll talk about the most powerful play on the basketball court is the alley-oop, right? I felt like I was being thrown into outer space, but I was really being thrown to a space to meet up with you all to get a slam dunk. And so I'm going to say, the more you continue to do what you're doing, don't stop at CNBC. Go to as many churches as you can, because you might get an alley-oop. You might find somebody that was just like me, who was looking for an opportunity to turn their pain into purpose. And now you've got 2 churches, and then 3 churches, and then 4 churches. You're not gonna get everybody, you know, but I think for me, you all showed up at the right time with the right program. And I was even fighting it. Y'all don't even understand what I'm saying. I was fighting it. I didn't want to do it, but I wanted to do it, if that makes sense. I didn't want to do it, but something in me knew that this mental health thing is something that I've got to deal with. And so I would just, the only other thing I would say in addition to that is I think, at least for this program that we're doing, I think we need to start adding male serving organizations and other youth serving organizations to sort of expand the reach of what we're doing, so that we can have more collaboration and more partnerships. Because I think that's, not only can that impact the numbers, but it can also change the optics to say, oh wow, more people, more organizations are concerned about this than just AKAs and CNBC. There's these other organizations that are coming alongside them to make that positive impact. But I do just want y'all to know that if it wasn't for them, I wouldn't be sitting here today.
Thank you, Pastor. I think we are done. Thank you, everybody, for coming.
Do you want to take this question?
One more, sure.
Okay, one more.
Okay, the focus today has been on depression, but a number of people have mentioned about serious losses in their life. I wonder if you would just kind of quickly differentiate between depression and grief.
Yes. There is a significant difference between grief and depression. Grief is if somebody has a significant loss and had been going through. Now, that's where congregation and the counseling comes in and see that if that grief is not associated with excessive inappropriate guilt, which is going along. Like if somebody has lost a son or a mom or dad, and there is normal grief that can last, and there's stages of the grief that you can go through that don't want to do anything, just want to feel down, maybe taking a day or 2 off from work, but is not going to that degree that he's not having anhedonia, which we say not enjoying things. He is not participating with his kids. He's not functioning. He's losing things. If you see those things coming in, excessive guilt, recurrent thoughts of that, saying that I am hoping that I will meet my mom, I want to join her, or I want to join my son, then that's a demarcation of life in you. If it lasts more than 2 months, then that's something about, you have to worry about a major depressive disorder coming up or the pathological grief coming up. So that's a differentiation between it. If somebody is able to function with that grief, and that's what in the beginning we said about men, that if somebody is having a blue day, 1 or 2 days of that is not depression, is not meeting all those criteria. But grief is expected, is normal, and one thing which I would encourage every one of you, whoever you are with, if somebody is going to grieve, encourage him to speak about it. We are not going to label him with depression. It's not depression, it's normal grief, but untreated grief will go into depression. And if you don't have enough support, and the support is which is the one psychosocial support I always stress on. If somebody is in isolation dealing with grief, that's the recipe for disaster. You don't want it. And maybe that, and thank you for bringing that point, that is a very important point. If somebody is dealing with grief, maybe he or she is more genetically vulnerable to go toward depression. Maybe the social system is not that much supportive towards there. there maybe our congregations can be more tuned in with them, see that it's a normal grief, or going towards that red line, as you said, when to refer them. That's a major difference in them.
And just real quick, as a pastor who deals with that type of situation, I have become again more sensitive to, I'm sensitive now to an entire family. I can go to a funeral now, y'all, and I can be standing right there by the casket, and I can almost tell, based on the way people approach it. Yeah, seriously, I can almost tell. I've done so many that I can almost tell, okay, we need to keep our eyes on this person. We need to check back on with that person. And the message that I get from people, sometimes I have to send a message back that allows them to reach out to me the next day or the next week. So I throw something out there to make sure that I keep it because of what I'm detecting. So I'll encourage those pastors who, or any faith leader or any person in a pew, that those of us who are closest to the situation and understand what just happened, if we keep our eyes on people and begin to differentiate grief, like you said, from, wow, you've been at this, you've been talking this way for a little too long. We need to find some other help or support. Those of us who are close to it, I think it's our responsibility to try to make sure we have the resources to help make sure they get the help that they need.
Thank you. Did that answer your question? Okay.
Thank you, Dr. Siddiqui. Thank you, Pastor G. I'm going to briefly introduce our interfaith prayer service. Those of you who are participating in making an offering with the interfaith prayer, if you could please come up to the front. Generally, when we do interfaith prayers, and we like to make a couple of acknowledgments first. We like to acknowledge that we don't imagine it to be comprehensive, right? We couldn't possibly get every tradition in the room, and we also don't presume that those traditions are internally monolithic. And also, we don't ask someone to share their tradition in an interfaith way. In other words, being in an interfaith setting doesn't mean that we want them to alter the way that they express their tradition or their faith. So we're really happy to have you all here. We have Pastor G is going to come back up and offer a prayer. We have Natalie Hadel with the pagan community. We have Imam Jamil Al-Razi and Ali Santisi from Mu'minin Mosque. We have Sam Hammonds with the Unlock Buddhist Temple, and we have Father Michael Hoyt from St. Thomas Aquinas Catholic Church.
So from a Catholic Christian perspective, this is what we try to do in the context of our parish, but then in the context of the larger churches, to create safe space for vulnerability, taking our motto from Jesus Christ, who was the vulnerable man, but through his vulnerability, we believe that brought about salvation and God's love. And so creating safe spaces for vulnerability comes in various ways. We have tried to create support groups. Also, I find that speaking about my own experience of depression and other experiences like that, to welcome that vulnerability, not only interpersonally, but equally seeing it as an opportunity for deeper connection with God, deeper connection with Jesus Christ, because we don't hold on to that vulnerability and the challenges that we experience for ourselves, but opportunities to grow in fellowship with one another and with God. So I'd just like to offer prayer that may God continue to bring about works of mercy, of vulnerability, of life-giving love, inviting all to deep communion with one another and with God through vulnerability, through our sadness and despair. These can become fertile grounds of hope, salvation, knowing that when we walk through the shadow of death, we'll never walk alone, because you are indeed by our side. Amen.
My name is Sam Hammonds, and I'm here representing Unlock Temple, Vietnamese Buddhist temple on the east side. And the practice of Buddhism or the practice of meditation has been a tremendous help to me personally. I'm not here trying to sell anything or convert anyone to my way of thinking, but rather share with you what has worked for me. I was in a deep, try to keep my emotions out of it, but I was in a deep, dark depression of guilt over a divorce, and led to years of alcoholism and drug abuse, and I was hiding it well. Had my own company, and ironically, we built churches. We built missionary Baptist churches and beautiful structures, but I was suffering deeply. I stumbled upon meditation through my artwork. I started doing oil paintings, and I found that after 4 hours of paying attention to nothing except what goes on at the end of the brush, for 4 straight hours, it gave me the peace that passes all understanding. When I sought out books to explain what was going on in my mind, they all led to some form of meditation, and most of those books either directly or indirectly led to the practice of Buddhism and meditation. And so that meditation, that rest that you give your mind, is where the peace comes from. It's where the clarity of mind comes from. It gives you more compassion for what others are doing and thinking and believing. It gives you a better insight through looking in their eyes as to whether they might be suffering too. It's a clarity of mind that I'd never had before. And so mindfulness meditation, if I were to just come up and you all knew my background already, I would just come up here and we would imagine a bell sounding, and we all take a deep breath in. As a matter of fact, let's do that. Let's just practice. We'll all take a deep breath. That sigh of relief is the peace. That's the practice of Buddhism.
Hello everyone. I'm here representing the pagan community of Indianapolis today. There's over 1,000 of us and growing. I'm not representative of every single person in our community because we all have different paths, different faiths, different beliefs. But the pagan community historically is one of, need me to speak up a little bit? Can you hear better now? All right. So I was saying that I'm here representing Indianapolis's pagan community. There's over 1,000 of us and growing. A lot of us have a lot of different beliefs and paths. However, we do historically have a lot of people who come from oppressed or marginalized communities. So in our community, we do have a lot of people who are struggling with trauma, with mental illness, people whose problems are so severe that they've been rejected from a lot of other communities and areas of their life, whether it be sports or religion or their family. So something that's very central to us, at least in our community here in Indianapolis, is we really try to check in and look out for one another, because we're all have come from, a lot of us have come from really rough backgrounds. So we try to check in and keep an eye out for one another. Today, as my prayer offering, I would like to call out to the ancestors of everyone here and everyone in our communities to help guide families to be able to recognize signs and symptoms of emotional distress and mental illness and developmental disabilities, to be able to recognize that with people who are struggling within their own family, and rather than rejecting them, instead support them and go out and reach out for help and to help educate themselves on how to help them best. I'd also like to call out to Hecate, Greek goddess. She's the goddess of anyone who does not fit into their community. She's the goddess of the homeless and severely mentally ill. She's known as the torchbearer. She walks in darkness and she brings the light into it, illuminating truth so that people can transform from what they're struggling with and become healthy and well and into the light.
In the Baptist tradition, I want to offer everyone an opportunity to bow your heads at this time as we begin to pray. Lord God, we come to you this afternoon seeking your face in the midst of what we all recognize as an important and challenging issue in our community. God, we ask you to comfort and relieve those who are troubled in their minds and are troubled in their spirits. Lord God, we ask you to bring these individuals hope, bring them peace, and bring them a sense of consolation, of a loving community like what is being exemplified in this room right now. In your mercy, Lord, we're asking that you might grant patience and courage to the families and to the friends of those who are struggling with some form of mental illness. I ask that you might increase their perseverance as they face these challenges, as they seek to recover. And in your mercy, we ask that you might protect and defend those who are living with any form of mental illness. Protect them, Lord, from exploitation. Protect them from addictions, and protect them from abuse. It is in the name of Jesus Christ that we pray. Someone say amen. Amen.
Assalamu alaikum. My name is Dr. Jamil Arazi, and this is Ali Santisi. And we stand before you as representatives of the Islamic faith. And our belief is that the entire earth is a masala, a place of prayer. We don't necessarily need buildings and structures, but we use those as well. But prayer in Islam takes a couple of forms. One is this traditional 5 daily prayers that we offer as a way, and within those 5 daily prayers, we find a great deal of spiritual uplifting and mental relief. We go to Allah and we ask him for his help within the different prayers, traditional prayers that we do, are those aspects of mental health, seeking mental health relief. But there's also the dua, which is an individual form of prayer that does not always have a structure to it, but there are many hundreds and thousands of duas that are recited, that have been recited over time from over many years. And the dua that we've chosen to recite to you today, that Ali will recite in the Arabic, is a dua that has traditionally been thought of as a dua for depression. So I'd like for Ali to.
اللهم إني عبدك ابن عبدك لأمتك ناصيتي بيدك ماض في حكمك عدل في قضاؤك أسألك بكل اسم هو لك سميت به نفسك أو أنزلته في كتابك أو علمته أحدا من خلقك أو استأثرت به في علم الغيب عندك أن تجعل القرآن ربيع قلبي ونور صدري وجلاء حزني وذهاب همي. آمين.
In English, what this is saying is, O Allah, I am your slave, son of your slave, son of your female slave. My forelocks is in your hand. Your command over me is forever executed, and your decree over me is just. I ask you by every name belonging to you, which you named yourself with, or revealed in your book, or you taught to any of your creation, or you have preserved in the knowledge of the unseen with you, that you make the Quran the life of my heart and the light of my breast, and the departure for my sorrow and a release from my anxiety. Ameen. Inshallah. Assalamu alaikum.
Thank you. Would you like that Hebrew prayer as well?
Sure.
No, I didn't know.
Our steering committee representative, Rabbi Reeves, and
Yes, here it is. It's a prayer, a very short but powerful prayer called Refuah Shlema. In Hebrew it reads as if Mishaberach Avatenu B'Matenu Avraham B'Sara Yitzchak Rivka Yaakov Rachel Leah Yivarech Et Yahava Elohim Refuat Anefesh Refuat Aguf Yachon Im Kol Chokai Amo Israel Baruch Atah Adonai Rofei HaCholim. In English it reads, May the one who is the source of blessing for our ancestors bring blessings of healing upon all of us, healing of body, of mind, and of spirit. May those who in whose care are entrusted be gifted with wisdom and skill, and those who surround them be lifted with love and trust, openness and support in their care. And may they be healed along with all those who are in need. Blessed are you, O source of healing. Amen.
Thank you, and thank you everyone for those offerings. A great way to close the luncheon. I'd like to invite up Carol Wills for some announcements and some closing.
Good afternoon. Thank you so much for being here, for contributing, and let's thank our speakers right now one more time. This has been a sacred time, and thank you that we have the opportunity to share from our various faith traditions as well. I have a few things to mention. The information at the back of the room is free materials on the right table that you may take with you. A collection of materials you may use during May, which is Mental Health Month. Feel free to put it in the foyer of your faith community, copy the handouts that are back there. If you would just take one and make copies, then more people could take a copy of one of those. NAMI Indianapolis has some programs also that you can host in presentations that you can host in your faith communities. And they are Bridges of Hope, which is about a 1-hour presentation which talks about what is mental illness, whether its effects on people, if it goes untreated, how can we, the faith community, play a role in helping, and also what is NAMI and what are the community resources that we can have. Also, there's a brochure, a few of them. Back here, there's another presentation called In Our Own Voice, and that brings in 2 or 3 people who have a diagnosis and are in recovery, and they share their story. And this breaks down stigma. It frees people for dialogue in the interactive session that they host. And then there's Ending the Silence, which is a program for youth. And again, a trained person would come into your congregation and present this. So feel free to call the NAMI State Office or the NAMI Indianapolis office. The number should be on the back of the brochures. And also I have a newsletter that goes out about every 2 months. It's the Wellspring newsletter. There's a laminated example of one of the issues. And in that, you're going to find several articles that would be useful, events that might be helpful to you to continue your learning path. And then it also has a resource of a book or some type of a video DVD that is useful within your congregation. And the last thing that it has this month is resources for Mental Illness Awareness Month. And there are links that I provide where you can download materials. And one of them is a matrix of where do I stand on this matrix of what are my beliefs about mental illness. And it really helps you assess your own attitudes. And so I encourage you to sign up. There's a sign-up sheet back there for that. This is also a time when we've encouraged you to make announcements about upcoming events that you want other people to know about. Are there any conferences, any meetings that you're hosting or that you know of that would be significant to the rest of us? Yes?
I hope everybody knows about the Faith in Indiana meeting assembly on Saturday at North United Methodist Church. Faith in Indiana is a group that is addressing and trying to hold our legislators accountable for human service needs and issues.
Oh.
It's on at North United Methodist Church from 1 to 4. Senator Joe Donnelly will be the keynote speaker.
Okay, that's this coming Saturday. North United Methodist Church at 38th and Meridian. 1 to 4, did you say? Okay. Faith in Indiana. That's excellent. That's my church, and I didn't even know that.
It used to be called Indiana.
Okay. Oh, okay. Okay.
It's now becoming Faith in Indiana.
I didn't read the church newsletter. I'm sorry. Next month, our session is on the criminal justice system and the mental health courts. So you don't want to miss that. Judge David Shahid will be with us, and it will be outstanding. Bring someone with you. I believe that's all the announcements I have. Others?
Announcement. Tomorrow is a little short notice, but the area health group is putting on a program on diabetes, psychosocial needs, just kind of related to in Kokomo at the conference center there. If you need more information, let me know.
Okay. I just remembered there is the Indiana Suicide Prevention Conference in June. And if you sign up for the newsletter, there will be an article in the next issue and a link to be able to register for that. All right. Dr. Jamil has agreed to give us the closing prayer. And thank you for coming, and please visit the table.
For the closing prayer, I would like to offer what is the first chapter of the Quran, which is the opening. So in the closing, we're going to do the opening, and its recite goes, and I'll do the Arabic and then I'll translate it in English. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanir Rahim. Maliki Yawmiddin. إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. Amen. It says, in the name of God, in the name of Allah, the most beneficent, the merciful. Praise be to God. Allah, most gracious and most merciful, show us the straight way, the way on which you have blessed, not the way on which you've shown thy displeasure, nor don't make us of those who go astray. Amen. Thank you very much.
Thank you. We'll see you next time.